important cells which are present are the germ cells. So then the second group of tumors which we have are the germ cell tumors. And then we know that the stroma which is present, the ovarian stroma which is present, will be a part of the ovarian stromal tumors. And these are the three important set of tumors that we will be dealing with. And most of the surgeries which have been shown to us are from the surface epithelial tumors. Coming to the surface epithelial tumors, which is also called as the germinal epithelium, we have three main important groups, which are the serous tumors, mucinous tumors, and the tumors showing differentiation towards the transitional epithelium, which are the Brenner's tumors. And the fourth important group is the endometrioid tumors, which resembles similar to what you have the endometrial tumors in the uterine corpus. So these are the four important tumors which arise from the germinal epithelium, and all of them can be categorized from benign, borderline to malignant, and the complexity of the anaplasia and the invasion which makes it malignant, while lack of invasion makes it benign, borderline, while the benign tumors do not show any features of anaplasia. The other important group is the germ cell tumor, of which we keep on seeing the most common tumors being the dermoid cyst or the teratomas, which are the most important ones. And then sometimes we can have malignant transformations in the teratomas. The malignant germ cell tumors are the dysgerminomas, which are counterpart of the seminoma of the testes. Then we have yolk sac tumors, choriocarcinomas, and embryonal carcinomas. Now, all these arise from the ovarian germ cell. But when we come to the layers of the follicles, we know that there are granulosa cells which are forming the layers of the follicles, and the theca externa and the theca interna cells. So from these gonadal stromas, we have the thecomas and the fibromas, which come as solid ovarian tumors. Thecomas being lipid filled, so appear more yellow on gross appearance, while fibromas appear dense white on gross appearance. The malignant tumors of these ones are the granulosa cell tumors and the Sertoli Leydig cell tumors, which we see uncommonly, but can be a source of chemotherapy. Should be requiring chemotherapy, especially in the malignant cases. Then the uncommon tumors are the Hyler cell tumors, which are usually the benign tumors, and very rarely we can have the vascular tumors and the leiomyomas, which arise from the ovarian hilar stroma and from the ovarian vessels which are coming from it. Now, why do these tumors develop? What is the pathogenesis behind it? There are various theories which have been proposed for the development of ovarian cancer. Some which negate each other also. The most important theory which has been proposed is the repeated trauma to the surface epithelium, and as a result, the surface epithelial tumors are the ones which are the most common ovarian tumors, and this is because of the incessant ovulation therapy. So repeated ovulations, that means repeated trauma to the germinal epithelium, leading to accumulation of mutations, and that would lead to surface epithelial tumors. The second theory which has been proposed is the gonadotropin theory, which will lead to increased estrogen excess, and that is what will lead to estrogen dependent tumors, especially the endometrioid tumors, similar to the ovarian tumors which is there, and may also be seen with the PCOD patients. The third and the most important theory, which came on much later and is the most favored theory these days, especially for the high grade serous carcinoma, is the fallopian tube theory. That actually the tumor, which is the fallopian tube serous carcinomas, are arising from the fallopian tube epithelium, and that is why it is important to see the pre-neoplastic changes and the neoplastic changes in the fimbria of the fallopian tube. Now, apart from this, we know that the ovarian tumors, as our previous speakers have also told us, are the important ones, which are the low-grade serous tumors, mucinous, endometrioid, and clear cell tumors and transitional tumors. All these are grouped as type 1 tumors. These type 1 tumors are stable genetically. So they have a RAS MAPK pathway through which they develop these tumors, and the precursor lesion is considered to be the epithelial inclusion cyst, which can be explained by the incessant ovulation. While the type 2 tumors are more aggressive, they
अभी
are
तो
high
बंद हो
grade.
गई होंगी,
They
कल
can be
सुबह
high grade
जाना।
serous carcinomas,
ये जो साइड
undifferentiated
में
carcinomas,
दुकानें हैं ना
or even the
कसने
mixed
वसने
Mullerian
की, इधर ही
tumors,
मिल
nowadays
जाएगा।
called by WHO as
यहाँ पे बहुत
carcinosarcomas,
सारे
the
ये
mixed
मैकेनिक
Mullerian
खड़े
tumors
रहते
not being
हैं
preferred, the
सुबह
terminology these
सुबह।
days. These tumors are high grade, have an unstable landscape.
हेलो,
Majority of them, nearly 4/5 of them, 80% show a P53
साइलेंट
mutation,
करने।
and these are the ones which are associated with BRCA1 and 2 abnormalities. So these are the
प्लास्टिक का
ones
चल
which will be
रहा,
showing
ब्लू
the
वाला
germline
दिया था मुझे।
mutations, as we have seen in the chats, and should be done the germline mutation testing should be advised to the family of these patients. The precursor lesions of these tumors is the one which is arising from the epithelial cells of the ovarian fimbrial tube. So, from the fimbriae of the fallopian tube. So, this has uh, been there. The good thing about these high grade tumors is they are sensitive to platinum chemotherapy and the PARP inhibitors because they are high grade tumors, so they are sensitive to chemotherapy. So, where does the pathologist come in? The pathologist comes in both in the pre-operative consultation and majority in the intraoperative consultation because most gynecologists do not prefer a fine needle aspiration because that may rupture the capsule and may lead to spread of the tumors. Intraoperative consultation, especially at the time of cytoreductive surgeries, especially in early ovarian cancer when one is not sure of whether the benign or whether it is borderline or malignant tumors, so should always be subjected to frozen sections. If frozen section facility is not available, scrape cytology can give you a very fair idea to an experienced pathologist whether we are dealing with a frankly malignant tumor or not. The other uh, experiences which we have in our setup are the crush smear cytology, intraoperative FNACs, imprint cytology smears, and of course the malignant cells in the cyst fluid as well as the malignant cells in ascitic fluid, which is the routine part of the staging procedure and can be done intraoperatively also. So the uh, reason for doing a frozen section is one, for diagnosis, two, knowing the extent of the disease, whether there are actually peritoneal deposits or there are peritoneal mimics of deposits like endometriosis or tuberculosis, or there are just fibrotic nodules. Maybe it is not a true metastatic disease, and to look for the adequacy of resection if you are dealing with the fallopian tube extension. So just showing you the gross pathology
हेलो.
changes. So this was an ovarian tumor in a
मैंने आपसे
22-year-old
बोला
girl
कि ढक्कन
who had come
मिला
with
है,
the
मुझे तो
simple
बोले कि
ovarian cyst. The surface was clean, smooth, no capsular breach, wall was thin, there were no mural nodules. So one should always look for, even in a completely cystic tumor, whether there is a small mural nodule which may show malignant. The other thing, if you have not been able to give the complete cyst to the pathologist, look out for cyst contents and mention the cyst contents, whether they are serous, mucinous, or hemorrhagic, because that will give you a fair idea what kind of, whether it is a serous or a mucinous tumor you are dealing with. So the mucinous tumor shows you the tall columnar mucin secreting lining with a basally placed nuclei in a benign one. And in a malignant one, we will have high-grade nuclear features of anaplasia and mitosis. While in serous tumors, we will get the surface cilia, similar to what you get in the respiratory epithelium or the fallopian tube epithelium. In multiloculated complex cyst, as a pathologist, we open up all cysts to look for any areas which have solid components or there are any papillae which are present, because these are the areas which should be looked out for, cut, and processed to look for any malignancy, especially in mucinous tumors, because in the same tumor we can have benign areas and malignant areas. So do ask your pathologist whether they have taken at least one section per centimeter of the tumor before calling it benign or borderline, because malignancy can be picked up easily. It is the later ones which would be there. So presence of this cilia on top, papillae formations, multiloculations, stratification, and high-grade nuclear anaplasia, mitosis, and atypia are the ones which will, with features of invasion, which will make it a malignant tumor, while benign tumors will show benign morphological features. So this is what we see under the microscope: multiple papillae with fibrovascular core. There are high-grade nuclei which are there, large nuclei, atypical nuclei with atypical mitotic figures. These are the ones which make us diagnose the malignant surface epithelial ovarian tumors, which of course you can see it over here, which are present. And sometimes we may even do mucicarmin stain and immunohistochemical stain for mucin if it is a poorly differentiated carcinoma, whether it is serous or mucinous type, because the high-grade serous will be requiring much more aggressive chemotherapy. Now, apart from the cystic tumor, sometimes you may have a completely solid tumor, or there can be predominantly solid tumor with cystic foci. It is good to send the tumor in entirety, because then the capsular breach can be identified by the pathologist. If at all you have not been able to remove it in entirety, please mention whether the surface which is there, the capsular breach has occurred or not, because that will be a very important part of your staging procedure. So what we do is we ink the capsule and then take the section to look for any capsular breach which is present or not. And this was a mucinous cyst adenocarcinoma which was there in this tumor. And here one can see that both the tumors, bilateral ovaries were removed and there were extensive surface proliferations. Of course, there were areas of intact capsule also. So this was from the bilateral malignant mucinous cyst adenocarcinomas. This was a high-grade serous cyst adenocarcinoma, completely solid with very few small cystic areas which had the serous fluid. So sometimes the high-grade serous carcinomas may look completely solid tumors, but they will not be dense fibrous like fibromas. They will be small, they will be friable and softer in consistency, which you can even pick up when you are cutting it from the knife. Now, this was a radical hysterectomy which was done. One can see the uterus with the cervix and bilateral mucinous cyst adenocarcinomas. One can see the mucinous contents in the various loculi and, of course, with the solid areas as well. So, this was another tumor which can show a solid cystic appearance with tumors showing, and there will be areas of necrosis as can be seen it over here. So we do look for areas of necrosis both in the primary tumor and after neoadjuvant chemotherapy, because after neoadjuvant chemotherapy, the chemotherapy response will be in the form of necrosis, fibrosis, and inflammatory infiltrate. So if you have, the patient has been lucky and you have been able to give neoadjuvant chemotherapy, there is reduction in the tumor size, the reduction in the ovarian size, then we look for tumor bed and tumor bed response and show it as a pathological complete response, partial response, or no response. That is how we report the post-chemotherapy tumor specimens. So now over here we can see that there are large papillae which are even infiltrating the capsule. So capsular infiltration and lymphovascular infiltration are two important things which we always look out for the ovarian tumors, and these should form the part of the standard reporting that you get from the pathologist. So serous tumors can sometimes show these calcifications which are called as the psammoma bodies, apart from the formation of these large glandular areas in well-differentiated tumors. And in poorly differentiated tumors, we will get just sheets of cells without glandular formations. So this is about the tumors of the surface epithelium. To summarize, serous are the ones which resemble like the fallopian tube lining with cilia on top of the surface. Mucinous resemble the endocervical mucinous lining. Endometrioid resemble the endometrial lining. Clear cells resemble the endometrial glands during pregnancy, and transitional cells which resemble like the transitional epithelium of the urinary bladder. So these are the important 5 groups of the surface epithelial tumors. And like our previous speaker has said, these are the most important tumors, and malignant tumors bilaterality is common in malignant high-grade serous carcinomas, or to the extent of 2/3 of these cases can be bilateral. The high-grade serous tumors will show p53 mutations and WT1 mutations. Immunohistochemistry is available for both of these. You may not need to go in for molecular study, and we usually use IHC surrogates for classifying low-grade versus high-grade serous carcinomas by doing immunohistochemistry for p53 and WT1. So these are the two important things that we always look out for. Coming on to this another case, here you can see the uterus is a postmenopausal one, very small, tiny, but we have bilateral solid large ovarian masses which was removed from that. And when we looked at the microscopy, these were mucinous adenocarcinomas in both the ovaries. And when we did an endoscopy, advised an endoscopy for this turned out to be a gastric carcinoma metastatic to both the ovaries, and the spread can be transcoelomic spread to bilateral ovaries leading to bilateral Krokenberg tumors. So this could be a mucinous tumor but of the origin from there. Just a couple of cases which I will show you. This patient had no ascites but a 7 into 6 centimeter mass, and CA125 was raised. So, and this was the crush smears which we prepared from the tissue which was provided to us from the, and this showed to be a mucinous cyst adenocarcinoma.
I'm sorry to interrupt you. Your time is up.
Yeah, I'm just going on to one interesting case. So this was a teratoma which was there in a 28-year-old lady, was shown calcification on X-rays, and one can see cartilage, glandular epithelium, as well as the skin epithelium or the stratified squamous epithelium, so mature cystic dermoid teratomas. Sometimes they can show hyperthyroidism with struma ovari formation, or even carcinoid when we call it them as monodermal teratomas, and rarely they may show malignant transformation. If they show trophoblastic differentiation, we call it choriocarcinoma. When they show extraembryonic differentiation, we call it yolk sac tumor. And when they show germ cell differentiation without any other thing, we call it dysgerminoma, as was shown to us in this one. So this patient had Schiller dual bodies on microscopic examination, 8-year-old girl, which had a yolk sac tumor with highly raised alpha-fetoprotein levels. Even if the tumor markers had not been done previously, and this was a component of a part of teratoma, we can do alpha-fetoprotein immunohistochemistry to make a diagnosis of the yolk sac tumor. So this is another case which is seen in a 11-year-old girl, and one found that beta HCG levels were slightly raised, and that beta HCG levels were raised in this patient of dysgerminoma because syncytial trophoblastic cells can be present in the septa of dysgerminoma. So that should not take you away that this young girl is having a trophoblastic malignancy or a choriocarcinoma, because these patients with dysgerminoma are extremely radiosensitive and small amount of HCG can be raised in these patients. A case of solid ovarian tumor, easily diagnosed as fibroma, which would be a spindle cell tumor on microscopy and easy to look out at it. If it is a thecoma, frozen section examination will show you lipid present in these cells. So both would be benign tumors. Uncommonly, we can get the granulosa cell tumors both in reproductive age group, which would be the adult granulosa cell tumors, and sometimes in young children, 10 to 12-year-old with juvenile granulosa cell tumors. So one should remember that juvenile granulosa cell tumors may also be seen in these patients. So sex-cord stromal tumors, uncommon but can be seen in young girls. So a mental biopsy has been extensively described by our previous speakers. So one should know that peritoneal implants and surface epithelial tumors can be non-invasive or invasive. And if invasive tumor implants, the progression-free survival is just is very high. The aggressive treatment is to be required for invasive implants rather than for non-invasive implants. So with or without treatment, the progression-free survival is 94% for more than 4 years. So diagnosis of ovarian tumors, all clinicians of you know it, so I need not repeat it. But tumor markers, ascitic fluid cytology and histopathology, which would remain the gold standard. I would still suggest that ascitic fluid cytology or an FNAC or a biopsy should be done before giving neoadjuvant chemotherapy, because after the chemotherapy response, we may not be able to find out the primary tumor histomorphology, which would be difficult to do it. So one request as a pathologist, when you send the tumor for histopathology, for frozen sections, do not add any fixative. When you are sending it for formalin sectioning, for a permanent sectioning, please send it in 10% buffered formalin, 10 times the volume of the tissue, which would be like this and not stuffed up like this, because this will cause autolysis of the specimen and we will not be able to give you any diagnosis. So with that one request as a pathologist to all the surgeons, I'll close my thing and would like to take any questions if there are. Thank you so much for this opportunity. Thank you, Dr. Sarita, and all the chairpersons for their kind words.
Thank you, Dr. Neeta. Can you please remove your slides?
Yeah, sure.
Yeah, stop sharing. Yeah.
Yeah, stop.
It was really lovely presentation. And you have left the dash is yours. So welcome, Dr. Sachin.
Thank you, ma'am. Let me just share my slides. Are my slides visible?
Yes, it's visible. So
Thank you, ma'am.
Yes. That's good.
Thank you, ma'am. And thank you, Sarita, ma'am, for giving me the opportunity to speak here. So I'll straight away start with my presentation, and it's about neoadjuvant adjuvant therapy in ovarian cancer. I'll skip a bit of part just to let you know, we all know ovarian cancer is one of the common malignancies and associated with high morbidity and mortality. Straight away start with a case. Let us assume there's a 60-year-old female with who presented with abdominal distension and discomfort and a lot of upper abdominal disease, and C1251080 with effusion also present and proven cytology positive. So now, how to approach such a case which have the patient has extensive disease and especially extensive disease in the upper abdomen. So here comes the role whether we should approach with the primary surgery or NSAT. Rama ma'am in her talk has already outlined two important trials which help us to decide whether we should go for primary surgery or NSAT. Actually, these were the two trials which introduced the concept of NSAT. While again touch upon these trials, this was the trial by Burgott, published in 2010, and they randomly assigned their patients to either primary surgery or neoadjuvant chemotherapy. And what they noted that the outcome, the survival was similar in both the arms, but the rate of optimal cytoreduction increased in those patients who received NSAT. But the survival outcomes were same. So this established that giving NSAT is feasible in ovarian cancer patients. Previously, it used to be primary surgery standard of care followed by adjuvant chemotherapy. The other trial, this was also touched upon by Rama ma'am, and it was the CHORUS trial. It was again a non-inferiority trial, and it also established that giving NSAT is non-inferior to primary surgery in ovarian cancer. Again, it also showed that the morbidity after surgery is less when NSAT is given. So after these two trials, NSAT was increasingly used across the globe, I would say, for ovarian cancer patients. But how to decide which patient should go for NSAT and which patient should go for primary surgery? Well, it is a little relative, but I would say that there are certain absolute indications which I hope all the surgeons here would agree with me, like poor performance status, poor nutritional status, root of mesenteric involvement, stage 4 disease, be it parenchymal liver or lung disease, and when extensive intestinal infections are required. These, for me, are absolute indications, and I hope and I think that most of the surgeons will agree to that. But the most important thing while deciding for NSAT is whether a CC0 resection is feasible or not, and that should be based on an assessment in an MDT, predominantly by radiologists, by the surgeons, and should also include other people like medical oncologists and also the palliative care physicians and everybody. But the most important assessment is by gynae surgeon, whether a CC0 resection is feasible or not, and that should take the things forward, whether to give NSAT or adjuvant chemotherapy. So, just for all the students, what are the drugs which we use in as chemotherapy in ovarian cancer, be it NSAT or adjuvant? The most important drugs are paclitaxel and carboplatin. Sometimes when giving paclitaxel is not feasible, say because of pre-existing neuropathy or the patient develops a hypersensitivity reaction to paclitaxel, the alternatives are liposomal doxorubicin and docetaxel. Can we use bevacizumab during the course of ovarian cancer? I will discuss in my next slides. Next is what is the optimal number of cycles. See, both these two trials, the Burgott and the CHORUS, the landmark trials which established that NSAT is not inferior to primary surgery, they use 3 cycles in NSAT and 3 in adjuvant. But what is widely accepted is that 3 to 4 can be used in NSAT and at least 3 should be given in adjuvant setting. So overall, ideally 6 cycles, but in NSAT you can use 3 to 4. But yes, the guidelines say if you assess that it may not be possible to do a surgery even after 3 cycles, you can go on up to 6 cycles in selected cases only. So, but try to give 3 in neoadjuvant and 3 in adjuvant setting. So there are some texts which also mention about dose-dense therapy. Just to introduce what exactly is dose-dense therapy. Now, before that, I would like to tell that these drugs are used every 3 weekly. So giving paclitaxel at 175 mg per meter square and carboplatin AUC 5 or 6, even every 3 weeks for 6 cycles, 3. What is dose-dense then? Dose-dense means that we are administering chemotherapy with less time interval between the treatments. And for ovarian cancer, there have been two ways we can do that. One is that carboplatin being administered every 3 weeks and paclitaxel every week, or both carboplatin and paclitaxel being administered weekly. So there have been few trials. I will not go into the details of those trials. They showed increased PFS and even OS in one of the Japanese trials, but they were also associated with higher toxicities. The weekly regimens, the dose dense regimen. So the usual preference among all clinicians worldwide is the conventional 3 weekly dosing, where we can use a kind of a modification of dose dense treatment. I will come to that later. So this was a trial which it was named as MITO-7 trial. It actually randomized patients between weekly dosing and 3 weekly dosing. The dose used in the weekly dose dense regimens, which were actually the dose dense regimens, the paclitaxel dose was 80 mg per meter square weekly, and carboplatin 3 weekly, AUC 5 or 6. This modified that regimen and used the dosing of paclitaxel 60 mg per meter square weekly and carboplatin AUC 2 weekly. So practically dividing the 3 weekly dose into 3 parts. What they observed that the side effects were actually less in this modified dose dense regimen with the lower dose of paclitaxel. And what I have highlighted here is the patients who are more than 70 years. In patients more than 70 years, if you see, weekly regimen was favored in terms of outcomes. Why? Because weekly regimen with paclitaxel of 60 mg per meter square was associated with less toxicity. So now it has become a very common practice to use a weekly regimen, especially in those patients who are elderly or who are in poor general condition, and the clinician thinks that she may not be able to tolerate a 3 weekly regimen, a higher dose regimen. So that's where we can use a weekly regimen in ovarian cancer patients. Otherwise, the standard of care remains a 3 weekly regimen. So now, what about bevacizumab? It is now being widely used in ovarian cancer, but what actually is the data for that? So there were 2 trials of bevacizumab in first-line setting for ovarian cancer. One was the GOG trial, another was the ICON 7 trial. This is the GOG trial. So important to note, there was a PFS difference. PFS was higher in the bevacizumab population, but the overall the OS was same. So there was no overall survival difference between bevacizumab versus no bevacizumab as maintenance therapy. This was the second trial, the ICON 7 trial. This also showed no overall survival difference in the whole population, but in a high-risk population, it showed that bevacizumab patients behaved better. The outcome was slightly better. And what were these high risk? These were stage 4 patients or who had suboptimal cytoreduction. So the doses used were different in these 2 trials. ICON 7 used a dose of 7.5 mg per kg and GOG 218 used a dose of 15 mg per kg. So these 2 trials were in the adjuvant setting. So bevacizumab was started with chemotherapy and continued as maintenance for 1 year. Can we use Bev in neoadjuvant setting? So there's not much data, but there are few trials which have shown that it is feasible and safe to give bevacizumab during NSCT also. But what it does, it increases the response rates, but there are no survival differences. So where should we use bevacizumab? What's the gist of all this data? It is optional in NSCT, maybe in cases which have massive ascites or effusion. In adjuvant setting, can we use in all stage 3-4 patients? There is no OS benefit demonstrated. But yes, in high-risk patients in ICON 7 trial, OS benefit was demonstrated. And what are these high-risk patients? Stage 4 disease, suboptimal cytoreduction, or massive ascites and effusion. So these are the patients where we can use bevacizumab in ovarian cancer. Now, but in spite of the best efforts, the median PFS of ovarian cancer patients is 12 to 18 months. So there is definitely need for something more, and insights into homologous recombination repair have changed the way now we treat ovarian cancer. And what is that? We all know that DNA is constantly damaged and repaired, and the The important two pathways are the single strand break repair and the double strand break repair. This is by base excision repair for single strand breaks, and the DSP repair using homologous recombination enzymes. So just focus on this base excision repair, seed enzyme, PARP1 enzyme. So this is involved in the repair of single strand breaks. And the BRCA1, BRCA2 and other homologous recombination repair enzymes are used in the double strand breaks. So just remember these two pathways of single strand break and double strand break repair. And now we'll try to understand the concept of synthetic lethality, which has actually introduced PARP inhibitors. And what it means is, in a normal cell, when both the ssDNA break repair and dsDNA break repair are intact, the cell viability is good. If there is one of the mechanism is deficient, still the cells are viable. But if both the mechanisms are deficient, that is, these are HR deficient cells or PARP enzyme is inhibited, then it results in cell death. So this is synthetic lethality. And just to highlight the terminology, which is sometimes confusing when we are deciding which patients should be given PARP inhibitors, how do we decide? Just understand this terminology. What is HRR? It's homologous recombination repair, which is an error-proof DNA damage repair pathway. What is HRP? These are cells which are homologous recombination proficient, and these cells are able to repair DNA damage, especially the DNA double strand breaks, by homologous recombination repair pathway. Enzymes I just showed you were BRCA1, BRCA2, and other enzymes like ATM, BRIP1, etc. What are HRD cells? These have homologous recombination repair pathway deficiency because of some mutation. What do you mean by HRD positive? That means that we have demonstrated that the homologous recombination repair pathway is deficient by some test. HRD negative means we are not able to demonstrate that the cells have a homologous recombination repair pathway deficiency. The test I will just tell you. So again, now homologous recombination status is actually made of two things. One is cause of the deficiency and other is a consequence. For us, important is the consequence. The cause can be either a mutation or it may be some epigenetic modification or anything. We need to see the consequence. And how do we see that consequence? By way of genomic scars or mutational signatures. I'll skip this. And so this consequence means what is the phenotype. We are not worried about the genotype. We are worried about the phenotype. And this is the standard test which was used, and it is the myriad assay for HRD. It uses loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions to classify patients who are HRD positive or negative. So they look basically into genomic scars which are created by certain we have seen that up to 50% of high-grade serous ovarian cancer patients have some form of homologous recombination deficiency. I'll skip these parts and I'll just move on to PARP inhibitors. So this introduced the concept of PARP inhibitors, and the first drug which was used was olaparib in the SOLO-1 trial, wherein BRCA mutated patients, they used olaparib as maintenance, and they saw that it was a dramatic improvement in the PFS as well as OS of ovarian cancer patients. So the important side effects of PARP inhibitors, the most common I will just highlight: nausea, fatigue, vomiting, and anemia. And anemia is the most common reason for dose reduction. So the landmark trials which have used olaparib and other PARP inhibitors are SOLO-1, Prima used niraparib, Paula-1 uses olaparib plus bevacizumab, and Athena Mono used rucaparib. So these three PARP inhibitors are most commonly used: olaparib, niraparib, and rucaparib. Niraparib is not available in India. Olaparib and rucaparib are used in India. So the important thing I want to highlight in the results of these trials is the population which do benefit from that. So one are the BRCA mutant. So they derive the maximal benefit. You see the difference in PFS: 56 versus 13.8, 37.2 versus 21.7, 22 versus 11. So they are the patients who derive the most benefit, the BRCA mutant population. Then HR deficient, I told you how do we identify by the test, and they also have good improvement in PFS with PARP inhibitors. I'll just take 2 more minutes. So important to understand is the HR proficient population. which are negative by that test, the Myriad test or other modifications of that test, that means that the homologous recombination pathway is not damaged in those patients. They have the minimal benefit from PARP inhibitors. Only a 3-month PFS was observed. So, and a meta-analysis from India, from Tata Memorial Hospital, showed that the patients who are HR deficient or BRCA mutated are the patients who will benefit from PARP inhibitors, not the HR proficient patients. So, what are the indications for PARP inhibitor in ovarian cancer? As maintenance therapy in BRCA mutated ovarian cancer, maintenance in HRD positive patients, and let me tell you, HRD positivity is defined by either that score which I showed you in the Myriad test, the genomic scar score, or mutations in tumor BRCA. So both BRCA mutated patients and who have a higher genomic scar score, more than 42 defined in the Myriad test, they are termed as HR deficient, and we believe that they have their homologous recombination repair pathway is deficient, and these are the patients who will derive most benefit with PARP inhibitors. So what about HR negative? It is approved by certain agencies, but if we compare the risk versus benefit, they do not go in favor of PARP inhibitors, and that was also proved in that meta-analysis. Can we combine bevacizumab and PARP inhibitor to have some more effect? Yes, one of the trials showed that it is feasible to combine bevacizumab with PARP inhibitor. It also showed that adding PARP inhibitor in HR proficient patient was not beneficial. So just to understand that you can combine, it is feasible to add PARP inhibitor and bevacizumab, but maximal benefit will be derived in those patients who are either BRCA mutated or HRD positive. Now, how do we take our decision? So this is a summary slide. First decision is whether we are using bevacizumab or not in our primary therapy. If we are using and the patient is, if we are not using and the patient is BRCA mutated, she will go on to receive a PARP inhibitor. If they are not BRCA mutated, then you can use niraparib or rucaparib. But first do an HRD testing. If the patient is HRD negative, the benefit of PARP inhibitor is minimal. If a patient is HRD positive, the benefit of PARP inhibitor is good. Next is if you are using bevacizumab as part of primary therapy and patient is BRCA mutated, you can either combine olaparib with bevacizumab, or you can just use PARP inhibitor. You can even take off bevacizumab. If the patient is not germline BRCA but HRD positive, again you can add olaparib. But if the patient is HRD negative, the trials have shown that there is no additional benefit of adding a PARP inhibitor to bevacizumab in HRD negative patients. So more or less in HRD negative patients, if you want to use some maintenance, you can use BEV. And in HRD positive or in BRCA mutated patients, you can use either bevacizumab plus PARP inhibitor or only PARP inhibitor as maintenance. So just to summarize, neoadjuvant therapy is equivalent to primary surgery in terms of survival outcome, but results in more optimal surgeries. Decision should be taken in MDT after detailed assessment by surgeon, radiologist, medical oncologist. Most effective drugs remain taxane and platinum. Bevacizumab can be added in high-risk patients. PARP inhibitor are now standard of care in maintenance therapy in HRD positive and BRCA mutated. And in select cases, you can add bevacizumab to PARP inhibitor as maintenance. So I conclude my talk here, and any questions are welcome. Thank you very much.
It was little reassuring because we see most commonly in the young age group, and most of them are benign. And even if they are malignant, they have a good prognosis. So ovarian germ cell tumors, which are derived from the primordial germ cells of the ovary, I think Dr. Neeta had already elaborated on that. It constitutes 15 to 20% of all ovarian tumors and 5% of all ovarian malignancies. And it is most common in the first 2 decades of life. 70% of these ovarian tumors are of germ cell origin if you see them in the second and the first decade of life. And out of these, 1/3 are malignant. Teratoma, we all know, is the most common, and it is 95% primitive germ cells, and they can differentiate into various tumors. If the germ cells that has not acquired the potential for further differentiation, then they stay as seminoma of the testes or dysgerminoma of the ovary. But some of the totipotential germ cells can also differentiate as embryonal carcinoma if they go on to the extra embryonic development and germ cell lines, then it may differentiate towards Wittline structures, going on to give rise to yolk sac tumors, or they may differentiate towards trophoblast and give rise to choriocarcinoma. If it develops on the embryonal differentiation, then they give rise to the teratomas. So this is the classification of the germ cell tumors of the ovary. We all know dysgerminomas, endodermal sinus tumors, which is now known as yolk sac tumors, embryonal carcinomas, polyembryomas, choriocarcinomas, and one of the most common teratomas, which can either be solid, cystic, and or they can be very highly specialized, developing like a monodermal teratoma, when we see as it as struma ovariae or carcinoid tumors. So when we see the histological types among the ovarian malignant germ cell tumors, the immature teratomas constitute 35%, and followed by dysgerminomas, which are seen in 32%. Immature teratomas, dysgerminomas, yolk sac tumors, and mixed germ cell tumors constitute 90% of all ovarian malignant germ cell tumors. The clinical presentation of all these germ cell tumors is quite common. Most of them will be asymptomatic, discovered incidentally on ultrasound, or they may present with non-specific signs and symptoms. Sometimes they present as an acute emergency of abdominal pain when they are associated with torsion, rupture, or hemorrhage, and also abdominal enlargement. So some of these tumors, as we know, they secrete SCG, and they can present with precocious puberty, symptoms of pregnancy because of the SCG production by some of these tumors. Fever or vaginal bleeding is seen in 10% of the cases. So the highest incidence is in the second and third decade of life, and the most common is dysgerminoma and the teratomas. So how to go about the diagnosis of these patients preoperatively? So a complete history is very important, followed by examination, imaging, which has already been described by the previous speakers. So we do a transvaginal, transabdominal, transrectal ultrasound, especially because these are unmarried girls. So sometimes you may have to go in for transrectal ultrasound as well. Abdominal CT scans, chest CT scans for lung metastasis, and MRI. A preoperative karyotype is indicated, especially if you're suspecting a dysgerminoma, because some of these can arise in a dysgenetic gonad, which could have a gonadoblastoma, and that can go on to have a malignant transformation, which is seen in more than 40% of the cases. So this is associated with some of the syndromes like Turner syndrome, Klinefelter's, and Swyer's syndrome. Tumor markers are also important for the diagnosis. So whenever you're suspecting preoperatively for ovarian tumor, presence of an adnexal mass on pelvic imaging or an elevated tumor marker should make you think about these germ cell tumors. But the diagnosis of these germ cell tumors is basically made on histology, that is the histopathological diagnosis after surgery. There's only one tumor which can be confidently diagnosed by a pelvic ultrasound, and as we know, that is the benign mature cystic teratoma or the dermoid cyst. These are the serum markers which are associated with the ovarian germ cell tumors. So you see that LDH, which is secreted by the dysgerminoma, and the HCG, which is secreted by embryonal choriocarcinoma. Mixed germ cell tumors can secrete HCG, alpha fetoprotein, and LDH because of the various components it has, and the yolk sac tumor, which will secrete alpha fetoprotein. So it is not only for the diagnosis that you do the tumor markers, but it is also helpful for monitoring response to treatment and for post-treatment surveillance. This is the immunohistochemistry markers, because sometimes even after the surgical excision, it is very difficult to make the diagnosis on histopathology. So immunohistochemistry will also help to confirm the cases. Now, the ovarian malignant germ cell tumors, they typically grow rapidly, and most of them are unilateral tumors, and they usually present at an early stage, that is stage 1. The spread is either by direct extension, hematogenous, or lymphatic. One should remember how to differentiate between the ovarian malignant germ cell tumors and the epithelial ovarian cancers. So we know that it is found in young females. Mostly they are stage 1 disease at diagnosis, and they always carry an excellent prognosis because most of them are chemosensitive. Staging is similar to the one which has been previously been described, that is the FIGO guidelines, and how to go about the surgical staging that has already been spoken. So I'm going to skip on this. This is again the FIGO staging. Now, what are the treatment options? So basically, the first approach is to do surgery. So the surgical management has to be done as a diagnostic as well as a treatment, and the extent of the primary surgery is dictated whether what you find during the surgery, and also consider the reproductive desires of the patient because they are young, they have fertility issues, so you have to keep that in mind when deciding for the surgical management. So if the lady has completed her childbearing and has no longer concerns of fertility, future fertility, then you go in for the full staging procedure, bilateral salpingo-oophorectomy and hysterectomy. But if she's desirous of having children and is wanting to preserve her fertility, a careful staging procedure, which was previously been described, has to be done along with the unilateral salpingo-oophorectomy. This is for the general germ cell tumors that I'm talking about. So it is very important in all these tumors to carefully evaluate the contralateral ovary. Dysgerminoma, the bilaterality is approximately 10 to 20% of the cases. Most of them are unilateral, but some of these subtypes may have an occasional involvement of the contralateral ovary. So it is very important to do a careful inspection. But any unwarranted biopsies of the ovary is discouraged, especially if it is a normal looking ovary. What about secondary cytoreduction and second look laparotomy? Because these malignant germ cell tumors are highly sensitive to chemotherapy, secondary cytoreduction, the role of cytoreduction in secondary second look laparotomy is questionable. It is not beneficial if the tumor is almost completely resected initially. So the complete resection of the tumor is, if it has been done initially as a primary surgery, then there is no need for secondary cytoreduction or second look laparotomy. But a second look laparotomy may be indicated in those where the disease was not completely resected. Nowadays, we have PET scan and CT imaging with advanced technology, and therefore that also will help in knowing about the residual disease or the recurrence, and therefore the role of second look laparotomy is less. What about radiation? Initially, dysgerminomas were to be treated by radiation. They had good radio sensitivity, good survival rates between 70 to 100%. But now with advanced combination chemotherapy, dysgerminomas can be treated effectively with chemotherapy because radiation itself will bring down the ovarian reserve, and because these patients are young, therefore chemotherapy is preferred. And the current combination platinum based chemotherapy for ovarian germ cell tumors is bleomycin, etoposide, and cisplatin. So the chemotherapy management strategies which are used for the malignant germ cell tumors, it is given as an adjuvant to the primary surgery and also to treat any recurrence. All patients except those with stage 1A dysgerminoma and stage 1A grade 1 immature teratoma should be treated with adjuvant chemotherapy. So completely resected disease post chemo can be cured nearly 100%. So on the right side, you can see the various regimes which are used for the ovarian malignant germ cell tumors. Recurrence can happen. All patients with germ cell malignancy, especially early stage disease, who are treated with conservative therapy for curative intent, warrant close follow-up. So how do we follow up them? Every 3 monthly for the first 2 years, because 90% of them will have recurrences in the first 2 years. So you need to do a clinical, radiological, and serological surveillance with the tumor markers. Relapse can be seen, especially sometimes you can see it with the 4 courses of the chemotherapy which has been given. And some of these patients who are platinum sensitive also, they can have a recurrence. And if the patients who have achieved a standard clinical remission of greater than 6 months after completing the BEP regime or another platinum-based chemotherapy comes as a recurrence, then they can be treated again with BEP. So these are the platinum sensitive patients. But those women who do not achieve remission with BEP or relapse within a few months, lesser than 6 months, then these are the platinum resistant and other treatment options to be considered. Chemorefractory cases are the surgical salvage aimed at achieving no residual disease may benefit some patients, and sometimes you may even have to give palliative options. Always remember, because these patients are young and you have to maintain fertility in most of them, so think about the toxicity, and this toxicity can be related to the surgical intervention or to the chemotherapy drugs. So avoid future infertility related to surgery, because you need to reduce the pelvic adhesive disease, because if you are doing extensive surgeries, unnecessary hysterectomies and unnecessary biopsies, it can give rise to adhesive adhesions in the pelvis and can cause problems in fertility. Now, risk of development is also of AML has been seen if you're using etoposide, but it is rare if only 3 cycles are given or less than 2000 milligram per meter square. So this is one of the drugs which is frequently used for ovarian malignant germ cell tumors. So long-term effects of chemotherapy on gonadal function should be minimal. Sometimes, and most of the times actually, there's return to normal ovarian function after you stop the chemotherapy drugs. Risk of ovarian failure is more with advancing age, high drug doses, and long duration of therapy. You can also use some chemoprotective drugs like GnRH agonist, which is given throughout during the chemotherapy cycles, because this will have a protective role on the primordial germ follicles. And once the chemotherapy is stopped, then the ovarian reserve becomes normal. A little about the different types of germ cell tumors. Dysgerminoma, this is a counterpart of seminoma, common in the second and third decade of life, and it is the commonest malignant germ cell tumor. So 80 to 85% of the patients are under 30 years of age, usually diagnosed during pregnancy or puerperium. So 75% of the patients present with stage 1 disease, bilateral involvement in 15 to 20%, and 5% of these tumors have syncytial trophoblasts. So therefore, along with LDH, there can be SCG production as well. So this pathology has already been spoken about, and one thing important which I wanted to highlight again is whenever you're suspecting a dysgerminoma, always do a karyotype, because this can be associated in dysgenetic gonads and therefore the higher incidence of neoplasms, and if there is a presence of a Y chromosome. The tumor marker for dysgerminoma is LDH. This is an algorithm for the management of dysgerminoma. For stage 1A, fertility sparing surgery is indicated, followed by active surveillance. For stage 1B and 1C, you can do a fertility sparing surgery, surgical staging. And if it has been properly staged, then you can go on with the surveillance. If not, then with the DAP cycles. And for stage 2 and 4, you have the fertility.
Oh, ma'am, your time is up.
Yeah, just few more slides. So the mature teratoma, again, we have already discussed about this. And the dermoid cyst, which is one of the most common, it is seen bilaterally in 10 to 17%. It is a slow growing tumor. Complications again are the same: torsion, rupture, infection, and malignant degeneration. So we all know that it has all the 3 germ cell layers. You can, when you do a cut section of these tumors, you can see the teeth, cartilage, bone, and Rokitansky protuberance is one of the most characteristic feature of mature cystic teratoma. This is the ultrasound of a cystic teratoma, and always be careful while doing a surgery that there is no spillage, because that can give rise to chemical peritonitis. So the surgery which is involved for this is a simple cystectomy. Rarely, if it is large, then you need to do a unilateral adnexectomy. Yolk sac tumors, the serum markers are alpha fetoprotein, and it is the third most frequent malignant germ cell tumor. Highest incidence is around 30 years of age, and it is highly malignant with a poor prognosis. Chemotherapy allows for fertility sparing surgery. So, for stage 1 disease, you can go ahead with fertility sparing treatment and followed by chemotherapy. For stage 1C to 4, again debulking surgery is recommended, and you need to give them 3 to 4 cycles of BAP chemotherapy. This is again the same algorithm for yolk sac tumors. Immature teratomas represent 35% of all ovarian malignant germ cell tumors, and the peak incidence is between 15 and 19 years of age, highly aggressive, and they contain all the 3 germ layers. And again, the pathology may show some of the 3 ectoderms, endoderm, and the mesoderm elements. Very important is how to grade this on pathology, because grading will depend, the treatment will depend upon the grading as well as the prognosis. So again, pathology of these and grading is important. So for the immature teratoma, again for the lower grade tumors and stage 1A, you can go in for fertility sparing surgery with active surveillance, stage 1A, grade 2 and 3, fertility sparing surgery, and surgical staging is required. Stage 1B, 1C, and the higher grades will need debulking surgery. And in some cases, very selective cases, after proper counseling, you can offer them fertility sparing surgery. But then, after they have completed their family, you may have to do the full definitive treatment. So, embryonal carcinoma is the one which is extremely rare, occurs in very young girls, and the mean age being 14 years. They may secrete estrogen, so they can give rise to precocious puberty. HCG is the basic tumor marker for embryonal carcinoma. Treatment includes staging laparotomy with unilateral salpingo-oophorectomy followed by chemotherapy, and the outcome 5-year survival is between 95 to 98% for stage 1 and 70 to 80% for stage 2 to 4. So this is the last, mixed germ cell tumors, which account for 5% of all malignant germ cell tumors. And the tumor marker may again be alpha fetoprotein, HCG, because they have mixed components, and treatment is with chemotherapy depending upon the malignant elements. Prognosis depends upon the size of the tumor and the relative size of its malignant component. So stage 1A, less than 10 centimeter lesions, the 5-year survival is good, approximately 99 to 100%, and for others it is 70 to 90%. So to conclude the take-home points, ovarian germ cell tumors have non-specific signs and symptoms. Always, whenever you are doing an ultrasound, if you find an incidental finding of a solid mass, it must raise the suspicion of malignant germ cell tumors. CTs, MRIs may be helpful, serum markers, but pathology is the cornerstone for the diagnosis of these tumors. Multidisciplinary team may be required. Surgery should be tailored depending upon the age, interest in preserving fertility, and stage of the disease. So the standard treatment is unilateral salpingo-oophorectomy for the young patients in early stages. Surgical biopsy of the normal contralateral ovary is not recommended because this can give rise again to problems in future fertility. But if the patient is premenopausal or menopausal, then you have to go in for full staging and total abdominal hysterectomy with bilateral salpingo-oophorectomy. Platinum-based combination chemotherapy is effective, and even incomplete excision of locally advanced disease, chemotherapy can give long-term survival up to 75 to 80%. If recurrence happens, it is an indicator of poor prognosis. Radiation does not have a role, and follow-up can be done with clinically, radiologically, or by the serum markers. And for now, we should have a national tumor registry and protocol for all these tumors. I'm not sure whether we do have it, but that is the need of the hour. Thank you very much.
I'm just going to show you. Can you show the answers, please? Full screen. Okay. So the questions, the first question, these were given by Dr. Kavita. All are ultrasound features of mature cystic teratoma except lines and dots appearance, tip of iceberg sign, hyper echoic mural nodule, Venetian blind appearance. So this is not a feature of mature cystic teratoma. Chemotherapy regimen for malignant ovarian germ cell tumors most commonly used is. So this, I'm sure you all of you know the answer. Most common tumor marker in dysgerminoma, again very easy. LDH. Next, Dr. Rama Joshi's questions were, what is the optimal cytoreduction as per GOG criteria? It should be residual disease less than 1 centimeter. Which of the following is the most significant predictor of survival in patients with advanced ovarian cancer? The answer is completeness of cytoreduction. That is the amount of residual disease. Dr. Charanjit questions were, which is the most common tumor marker used for monitoring epithelial ovarian cancer? Again, very simple question, CA125. What is the advantage of using serum biomarker HE4 as a complement to CA125 in ovarian cancer diagnosis? So it is better specific in distinguishing malignant from benign masses. So HE4, especially in premenopausal young patients, it is better because CA125 can be raised in endometriosis as well as in tuberculosis. So HE4 helps you in differentiating. Which of the following statements is true about tumor markers in ovarian cancer? Tumor markers like CA125 and HE4 are part of algorithms for assessing the risk of malignancy in ovarian masses. That is the correct answer. Dr. Subhu's questions were, unilateral salpingo-oophorectomy can be considered in the following. The answer is A, stage 1 dysgerminoma. The largest number of patients with epithelial ovarian cancer is found in, the answer is A, 60 to 65 years age group. Dr. Neeta's questions were, the most common clinical manifestation associated with functional stroma of ovarian tumor. The answer is estrogenic. So the clinical manifestation is usually because of the estrogenic part, which you find in granulosa and theca cell tumors. Then the question, a 12-year-old girl with ovarian tumor is reported to have dysgerminoma. Which of the following statements is not true? The answer is alpha fetoprotein is not elevated in a dysgerminoma. The cost-effective method of reducing risk of ovarian cancer and BRCA mutations is risk reducing bilateral salpingo-oophorectomy. That is the only that is the only procedure that can reduce the risk in BRCA mutations. With ovarian endometrioid carcinoma, the answer is 3, that is CTNNB1. Brenner tumor of the ovary it's a surface epithelial tumor. That is the answer is 2. Question number 16, which procedure is not routinely a part of surgical staging for ovarian cancer? So diagnostic laparoscopy is not a part of a routine surgical staging for ovarian cancer. And it should not be done for ovarian cancer when the mass is suspected to be an ovarian malignancy. What are the steps of surgical staging in correct order? The answer is B. That is first is BDAC, which is opening the abdomen first, and then collecting peritoneal fluid. And just scroll up, please. Scroll up. Okay. And no, just scroll up. No, oh, okay. The next question is, how is ovarian cancer staging done? It is surgical pathological staging. There is histopathology, that is, it's a surgical staging, and histopathological. After surgery, it's histopathological staging. Goff symptom index includes all except, the answer is abdominal lump. So it includes that is the bloating, loss of appetite, urinary symptoms. Abdominal lump is not a symptom in the Goff symptom index. All is true about CA125 except that the answer is B, stage 1. 80% of patients may have elevated CA125.